I am Dr. Pritam. So today we are going to study about which bone? Radius. So what is the name of this bone? This bone? And this? Radius. So these two bones are radius and this is ulna. Okay. So ulna has been covered, no? So for any bone, whichever is in pairs, we need to do determine the side of the bone. That is, it belongs to which side? Our right side or our left side? Okay. So you have been taught about the anatomical positions. You know na, this is the anatomical position. This is not the anatomical position. Okay. So based on this, the radius presents in the medial side or the lateral side? Lateral side. Okay. Similarly, in the lower limb also, there is another bone which is in the lateral side. Which bone? Tibia. Tibia. So radius is homologous with the tibia. Homologous means it has similar features as the tibia. Okay. Now coming to some points under which a bone has to be described. A bone has to be described under introduction. If a teacher tells you to pick this bone, he will not name it, he or she. Then you need to say that this is a right or a left radius. For this you need to determine which side it belongs to. Okay, fine. Now the second thing is, then you need to see that this is the radius of left side of the body, left forearm, and why have you said it that it belongs to the left side? You need to describe that. For this, you need to follow certain points. First of all, let me clear that whichever bone is present in pairs has to be described based on their side. Followed by, they need to be described based on their parts. Like how many parts the radius have, then their surfaces, borders, and then their muscle attachments, muscle insertions, origin, as well as, you have been in that class, no?
Yes, but they
Okay, fine. So then muscle attachments and muscle insertions, you need to know that. And certain clinical correlations. You know na clinical correlations? Clinical correlations means that this bone has certain features, like if fracture occurs in this bone, what type of paralysis or what type of nerve injury will occur. We need to know that. Like some clinical anomaly belongs to only this bone. Okay, like these things will not occur in any other bones. We need to know that. So as I have told, it is a long bone of the forearm present laterally. See, this is the front side of the radius. This is right radius. How to know this is right radius? For this, you need to pick up the bone. This is radial tuberosity. This projection is radial tuberosity. This should always face medially. Okay. And this is this tip. This tip is styloid process. This should always present laterally. Now you need to pick up this bone and always determine these two sides. The third point is, in the medial side there has to be a interosseous border which is sharp. Okay. Now in this bone, these are fiber bones. If you have the real bones, then it is good. In real bones, you will be seeing these margins more prominently. These margins. In the real bones, these are more prominent. In fiber bones, it feels a bit tubular-like structure, and these structures are also not that much prominent. So what you can do if you are having the fiber bones, usually we used to collect the real bones from our seniors. Since you are the first batch, you need to contact your other relevant institutions for the bones, for your seniors. Now, because these are not provided by the departments. Now for studying these bones, these fiber bones, what you can do? You can just draw the borders here. So before exam, you can see the borders, the surfaces, the muscle attachments. You need to draw with The origin you need to draw with red and insertions with blue, and you need to draw the borders with black, so that you can, by picking up this bone, because in the exam you will be having many bones, so not only radius, so you need to by seeing the bones only you need to revise, like this is this thing, this is borders, this is surface, this is styloid process, and here muscle attachments are there, biceps brachii, supinator, like this. So this is the right radius. The right radius is having radial tuberosity on the medial side. This is the sharp interosseous border I was talking about. This goes downwards, and here a triangle like projection is there. You need not know this. Then this is the anterior border which is going downwards and forming another triangular like structure, and below this is the styloid process. So, and this styloid process should always face laterally. Now in this bone, this is the left bone. Why this is the left bone? Because it is facing medially, the styloid process facing laterally, and this is the sharp interosseous border. Now if I do like this is like feeling like the right bone also. No? So to determine this, in real bones actually, this part is sharp. This sharp, here it is also sharp. This sharp part you need to determine, it should always face medially, the interosseous border. If I do like this, the interosseous border is facing laterally, on the lateral side. So it will not occur. So and for your understanding, like you can just pick up the bone and see this below part. This is for your understanding. In the below part, it is smooth usually, and behind this there are certain tubercles, ridges, groups. These are pointed structures. So in this way, you can just pick up the bone and like you can feel the bottom part. This radial tuberosity you need to understand. This should face medially, and then the tubercle part should face posteriorly. So like this, you can determine that this is the left bone. Okay. Now coming to side determination, I have told you. Now anatomical position. It is placed vertically in the body. This is vertical. It has three parts. The upper end, the lower end, and this part is shaft. Now the upper end has three parts. This is the head. This disc-shaped structure is known as the head. So, and this constricted part is below head. What we are having? Neck. And this is the radial tuberosity. In the shaft, we are having borders and surfaces. Okay. In the shaft, medially we are having the medial interosseous border, which is sharp. Anteriorly, we are having the anterior border, and posteriorly, we are having the posterior border. Okay. And in the lower part, there are this anterior border. Okay, we will see these things. Now the shaft is convex laterally with a sharp medial interosseous border. I have told this. The posterior aspect of lower end has many ridges and grooves. Now coming to upper end, I have told that it consists of a disc-shaped head, neck, and tuberosity. The upper end of head is concave. See, this is concave. Concave you know na? This is concave, this is convex. So the upper end of the head is concave and it articulates with the capitulum of humerus. What is articulation? Joining of two bones. Okay. Medially, it articulates with the ulnar notch, and this forms the superior radioulnar joint. Remaining part is enclosed by the annular ligament. This ligament is very important. I will discuss this thing. And the constricted region just below the head is the neck. So here there is a notch. Notch is like a small depression where the ulna attaches, okay, in this notch and forms the superior radioulnar joint. Superior means above. Below also there is a notch which forms the inferior radioulnar joint. What type of joint is this? What type of joint it forms? Pivot joint. Okay. Joints has been covered na in theory class. Below the medial part of the neck is the radial tuberosity. The tuberosity is rough posteriorly and smooth anteriorly. This is the tuberosity. On the posterior aspect, it is rough, and anteriorly, it is smooth. In the posterior aspect, there is insertion of a very important muscle which we have discussed in our arm. Which muscle? biceps brachii. Okay, it attaches in the posterior aspect of this radial tuberosity and originates from there is short head and long head. Short head from the coracoid process, long head from the glenoid. Okay. So this is this cross section. Here it will be ulna. This is radius head. So if we place it like this, we will see this thing in the body. This is the concave disc structure of the radius, which is the head. It is surrounded by a ligament. This is annular ligament. The remaining part is ulnar notch, where the ulna attaches, and here it is the annular ligament. Now, why this annular ligament is important? Because in us, like in adults, the annular ligament is cylindrical in shape. Okay, but in children, it is tubular in shape. So, what problem it will cause? Pulled elbow. What is pulled elbow? Like you will see that sometimes parents or like children keepers, what they do, they pull up their children like this. This is not good actually. You will see that after some time he or she will like hold his elbow like this, and will keep on crying. You cannot just move his elbow. He or she will not allow. But they will not also say that they are having pain here. They will just hold their elbow like this. So this is the classical representation. If you take the child to a pediatrician, he or she from the door will see and tell that this is pulled elbow case by knowing the history. So what happens in children, the annular ligament is tubular in shape, so the radius just slips out while pulling. Okay, but in us, it is cylindrical in shape, so it gets constricted and cannot come out. Okay, so you will never see pulled elbow in adults. Okay. Now the shaft has three borders: anterior, posterior, and interosseous. And in between anterior border is in front. This is here we are having the anterior border forming an oblique line. It will form an oblique line from the front of the radial tuberosity and come downwards. And this medial sharp border is the interosseous border. And posteriorly we are having the posterior border. Now in between the anterior and the interosseous border, we are having anterior surface. And in between anterior and posterior border, we are having lateral surface. Okay, we will see these things. And in between posterior and interosseous border, we are having posterior surface. So let us see this thing one by one. See, this is the anterior border, this border. You are seeing now? And this is the medial interosseous border. Why it is named interosseous? Due to interosseous membrane. But why interosseous? It is present in between two bones. So this is the ulna, this is the radius, and in between we are having the interosseous membrane, which covers 3/4 of the bone. 3/4 means this is the full space, and leaving the above space, the below 3/4 will be covered by the interosseous membrane. So this is the anterior border. This is the anterior border, and this is the medial. This is the surface, anterior surface, and this is the medial interosseous border. Then this is the styloid process. Posteriorly, we are having another border. This is the posterior border. Now you are understanding? So, anterior border, medial interosseous border, in between this surface is facing anteriorly. So, this is the anterior surface. anterior border behind posterior border. Now this is the surface in between them. This is facing laterally. So this is the lateral surface between anterior and posterior borders. And interosseous border, and behind there is posterior border. In between it is the posterior surface. The same thing goes downwards in the lower end. In the lower end, the anterior surface goes downward and follows the anterior surface of the lower end. Laterally there is lateral surface, posteriorly there is posterior surface. Along with this, there are two more surfaces, namely medial and inferior surface. Medial surface will face medially. This surface, this surface is known as the medial surface. This lower small surface. And inferiorly there is inferior surface. Here we are having the concave shaped head. Here we are having the inferior surface. This inferior surface is very much important. There is if we divide this surface, we are having the quadrangular half and the triangular half. One attaches with the lunate, another attaches with the scaphoid bone. We will see these things. See, if we cut the bone like this, a transection we make, we will see these structures. I have already discussed these things. So this is the anterior, this is the posterior, this is the interosseous border. In between anterior and interosseous, we are having the anterior surface. This is the posterior surface, this is the lateral surface. Now I have told you that the anterior border begins from the radial tuberosity, runs downwards laterally across the anterior aspect of the shaft. This part of the anterior border is called the anterior oblique line. This is the anterior oblique line. It goes like this. So it is forming an oblique line. So this is the anterior oblique line and it goes downwards. Now the upper part of the posterior border runs downwards and laterally, forms the posterior part of the tuberosity. The lower part of the posterior border runs downwards along the middle part of the posterior aspect of the shaft to the lower end. Okay. Basically the posterior border begins from the behind the radial tuberosity and goes downwards and continues with the posterior border of the lower end. Now the interosseous of the medial border is easily identified. If you are having the real bone, you will see that the medial border is very much sharp. Like if you like slide with your finger, it may cut your finger also. So is easily identified as it forms a sharp ridge which extends from just below the tuberosity to the lower end of the shaft. Near the lower end, this forms the posterior margin of a small triangular area. This is not that much significant. Now, the anterior surface lies between the interosseous. I have told this thing, posterior surface, lateral surface have been covered. Now, in the upper part of the bone, the lateral surface expands into a wide triangular area as it extends to the anterior and the posterior aspect of the bone. The lateral surface show a rough area near the middle part of the shaft. See, this is the lateral surface and this is forming a triangular like structure. Actually here it is not that much appreciable also. You will see a small triangular area that is formed by the lateral surface in between the anterior and the posterior border. Here the marking has not been done. Now coming to the lower end, I have told you it has anterior, lateral and posterior surfaces which continues with the corresponding structures, and then we are having the medial and the inferior surfaces. The medial aspect of the lower end has the medial aspect of the lower end, this is the lower end. Now the medial aspect, why I am saying this is as medial? Towards? Close to the body, midline. Okay. So this is the medial aspect of the lower end which is an articular area. See, this is quadrangular in shape. It articulates with the lower end of the ulna to form the inferior radio-ulnar joint because it is having the inferior ulnar notch. Just above the notch, there is a triangular area bounded posteriorly by the interosseous border. Not that much important. Now, the posterior aspect of the lower end is marked by a number of vertical groups separated by ridges. The most prominent ridge is called the dorsal tubercle, which is placed roughly midway between the medial and the lateral aspect of the lower end. See, I have told in the beginning of the class, the front part is smooth. Behind it is rough. You will see certain grooves and ridges. These are certain like hilly type areas. You will see in between the grooves and tubercles, you will see that there is a very sharp one here. It is the dorsal tubercle. Why it is named dorsal tubercle? Because it is present in the dorsal part, not ventral. So you like study anatomy in this pattern. Every name has been given accordingly. Like all the flexor muscles, we name it flexors. All the extensors muscle, we name it extensor. Okay. Pollicis means thumb, hallosis means great toe. In this way, the names have been given. So you don't need to mark these things up. So immediately medial to the tubercle, this dorsal tubercle, there is a narrow oblique groove, and still more medially there is a wide shallow groove. These are having some tendon relations. We will see these things. The area lateral to the dorsal tubercle shows two grooves. Grooves means depressions type, separated by a ridge. There will be a ridge, sharp projection, and alongside both the sides there will be having grooves, that is depressions. The inferior surface, and all these things are present here only in this small portion only. The inferior surface, you are understanding na? This projection is the dorsal tubercle. Medially there are certain structures, laterally there are certain structures, laterally there is another ridge, and in between ridge there are certain groups. Okay. Now the area lateral to the dorsal tubercle shows two groups. I have told this thing. It takes part in forming the wrist joint. It is subdivided into a medial quadrangular area. I told these things that articulates with the lunate bone, and a lateral triangular area that articulates with the scaphoid bone. Now, when a person falls in road traffic accident, usually which bone is broken? Like among the carpal bones? Carpal bones. These are the carpal bones. 8 carpal bones forming the wrist joint. Scaphoid. Scaphoid is broken. Okay. Now, why the breaking of scaphoid is a very serious thing? You will see that usually the person is obese. Sometimes you will see they fall like this. And when they fall like this, if it is a very trivial injury, trivial means like a very mild injury. Usually the injury will not be that much heavy. You will see that the person will tell that he is having pain here. You will do X-ray. Usually the scaphoid fracture is not appreciated, but clinically if you press here, he will do like this. Okay. So that implies that there is a fracture. Now, scaphoid fracture is not good because you need to keep a cast for at least 6 weeks, and after that also, if the bone doesn't join, we need to proceed with surgery. Why? Because scaphoid undergoes avascular necrosis. What is avascular necrosis?
Blood vessels are
Blood vessels?
blood vessels do not supply.
Yes.
So in epiphysis and diaphysis there is an epiphyseal plate. If the blood vessel, if the epiphyseal plate is not there, the blood vessel can't enter the epiphysis. So there will be no blood supply to the epiphyseal area. It is called avascular necrosis.
So why it doesn't occur with lunate or any other carpal bones? In scaphoid, what you will see, the blood proceeds from the tail. You will be taught carpal bones in the upcoming classes. So there you will see that the blood supply will go from the tail to the body, then to the head. And in scaphoid, usually the head is broken. And if the head is broken, the proximal part, the blood supply will not go. And it will break the supply of blood to that particular bone, and it will cause necrosis, that is death of the bone, and due to avascularization, no blood supply. See, what do you mean by insertions? Muscle insertions? And origin? So a muscle has a starting point and an end point. Okay. So radius is having certain insertion of certain muscles. biceps brachii, supinator, pronator teres, pronator quadratus, and flexor carpi, brachioradialis. Now, biceps brachii usually attaches, as I have told you, to the posterior part of the radial tuberosity. And supinator on this is the lateral surface. Supinator usually inserts here, exactly at the lateral surface, but it gives its fibers like this, anteriorly and posteriorly. So, the supinator usually covers the whole area in this fashion, almost 3/4 or at least half. Then comes pronator teres. It is present in a rough area on the middle of the lateral surface. So just below the supinator, in the rough area, there is a rough area. Here the pronator teres inserts. And brachioradialis will insert in a very small region in the lower part of the lateral surface, just above the styloid process. And pronator quadratus, it will insert in the lower part of the anterior surface and triangular area on the medial side of the lower end. So to simplify, the pronator quadratus will be somehow here, the brachioradialis will be here, pronator teres will insert here in this region, supinator in this region, and biceps brachii in this region. We will see the schematic picture also. See, here the insertion of biceps brachii is occurring. Then this is the supinator. As I have told you, it gives a front fiber and a posterior fiber, and in this way the supinator muscle inserts. Then this is flexor pollicis longus. These are origin muscles. All these blue are insertion muscles. Like what has been colored in blue, this muscle inserts here, and what has been colored in red, these muscles are having their origin. Okay. Now this is the insertion of pronator teres, and in the lower part, in just lateral to the styloid process, a bit above, there is a brachioradialis muscle insertion, and in the below there is capsule of wrist joint. Why there is a capsule of wrist joint? Because scaphoid and lunate inserts here, articulates here. So in between bone articulation, to prevent friction, there are certain capsules and fluids, so that both the bone doesn't undergo friction. Due to friction of bones, which disease of knee occurs usually in elderly? Osteoarthritis, not porosis. Porosis is decrease in bone density. Okay. Osteoporosis you will see usually in after menopause, but in elderly you will see it after 65 years. Okay, around roughly 65 years. So in case of females, we need to evaluate the patients from 45 to 50 years onwards, to look for osteoporosis. You will easily see that your parents who are females, your mother or your grandmother, they will tell that they are having pain mostly in the proximal regions of this or arms. This is usually due to osteoporosis if they have crossed around 45 of age. But your father will not say these things. They will say after 55 or 65. Then we usually do DEXA scan, T-score. These things we do, lab tests, and in this way we can determine whether they are having bone density of how much. Usually if it is between 1.5 and 2.5, okay, these things we will see in other classes. In between, if the range is in this range, then usually the person is having somewhat in the middle condition. It can be resolved by giving medications, but if crosses 2.5 T-score, then usually it's a severe condition and proper treatment needed. See, these four muscles are having their origin from the radius. Flexor digitorum superficialis. Why it is named flexor digitorum superficialis? Digitorum because it gives its tendon to the digits, and flexor because it is present in the flexor region. Okay. Superficialis because in the arm we are having superficial and deep muscles. So the superficial muscle is, so due to this region, this is known as the flexor digitorum superficialis. In the cadaver also you will see that usually the flexor digitorum superficialis will be a very big muscle. Whenever you just open the skin and remove the fascia, after removing the fats, you will see that a big muscle comes which gives four whitish like structures to the digits. Okay. This is the flexor digitorum superficialis. Flexor pollicis longus, as the name suggests, it is also present in the flexor region, and pollicis means it gives its tendon to thumb. So flexor digitorum superficialis, it originates from the upper part of the anterior border, from the oblique end. This is the anterior border, and from this oblique end, the flexor digitorum superficialis originates. See, this is the oblique part, anterior oblique line. From this, the flexor digitorum superficialis originates, and this is the part, the medial part of the this is the anterior surface. Medially or almost in the anterior surface, you will see the origin of flexor pollicis longus. See, this is the thumb, this is the anterior surface. So the flexor pollicis longus goes like this. You can easily identify in the cadaver also. And digitorum goes like this. Then abductor pollicis longus. Why it is called abductor? Abduction. It causes abduction. It also gives its tendon to thumb, and it is present in the upper part of the posterior surface. An extensor pollicis brevis will present behind. So it is present in the small area on the posterior surface below the area for adductor pollicis longus. So extensor pollicis longus, as the name suggests, it is present in the extensor compartment, behind compartment. So it is present in the posterior surface. See, this is extensor retinaculum, then superficialis pollicis. This is abductor pollicis longus, and just below we are having the extensor pollicis brevis. So just correct this point. If you are taking pictures or writing it down, just correct this point. This is abductor pollicis longus. Below the area for abductor pollicis longus, not adductor. Now there are certain other attachments also. Articular capsule of the wrist joint having attachments for anterior and posterior margins of lower end of styloid process. So this is the styloid process. It is having an anterior margin. This sharp part is anterior margin. There is a posterior margin, and it forms the boundaries of the capsule of the wrist joint. So let us just complete the topic. So in the articular capsule of the wrist joint, there are attachments of anterior and posterior margins of the lower end of the styloid process. So this is the capsule. Here the capsule of the wrist joint is present anteriorly, anterior margin, posteriorly, posterior margin of the styloid process. Simple things. Now articular disc of inferior radio-ulnar joint. This is the radio-ulnar joint is formed here. It is having attachment for the lower border of the ulnar notch. This thing you know, if radio-ulnar joint is forming here, it will automatically have the lower border of the ulnar notch. Then there is interosseous membrane. I have told this thing. Oblique cord is not that much important. It is present just below the radial tuberosity. An extensor retinaculum will be a fiber-like structure present just in the extensor region. Like this is the extensor part. Here you will see, if you dissect, there is a fiber-like structure like a sellotape. This is the extensor retinaculum, and in the front we are having the flexor retinaculum. Now coming to the lower end of the radius, there is a groove behind the medial part of the lower end where the extensor digitorum and the extensor indicis tendons inserts. Now the oblique groove medial to the dorsal tubercle, this behind tubercle, it has tendon of extensor pollicis longus. And the groove lateral to the dorsal tubercle, there is tendon of extensor carpi radialis longus and brevis. Now the lateral aspect of the lower end of the radius is crossed by the tendon of the abductor pollicis longus and of the extensor pollicis brevis. So basically, if you go through this picture only, you can just make these things up by yourself. You don't need to mark these things up. If you are seeing a muscle in the medial part, just say medially. If you are seeing it in the medial 1/3, just say I am appreciating this in the medial 1/3. Just say like this. You don't need to just mark these things up like in book it is written 2/3. You need to say 2/3. Not like that. You understand these things, and in this way you proceed. Now ossification. What is ossification? Formation of bone. So there is a primary center and a secondary center, and there is also another center for the radial tuberosity, which occasionally, like in rare instances, they ossify. So the primary center is usually seen in the in utero life. The primary center is usually seen in the in utero life. So basically there is a primary center and a secondary center. The primary center usually appears in the in utero life. In utero means? In utero means inside the mother wombs. Okay. The whole 9 months it is told in utero. Okay. Like inside the uterus. So in the 8th week of fetal life, the primary center appears. Why this 8th week of life is significant? Because during this period, usually the heartbeat is appreciated under the modalities we are having. Usually in USG it is not that much appreciated, but there are certain other modalities also. In this we can appreciate the heartbeat. The secondary center appears in the lower end in the first year and joins the shaft during 18 years of age. So you always remember in forensic you will study that there are many bones in our body which ossifies very late in our lives. Like the pisiform bone, one of the carpal bone, it ossifies at 12 years of age, 9 to 12. This bone ossifies at 18 years of age, so basically you are having it ossified by now. And like there are certain other bones also which ossifies in 45 years of age also. Okay, the sternum, some parts of sternum ossifies at 45 years of age. This is sternum, you know na? This is sternum. Now, a secondary center appears in the head of the bone during 4th or 5th year and fuses with the shaft during 16th year. So this is head. In the 4th or 5th year of life, one secondary center appears which joins with the shaft. And occasionally I have told this thing. Now coming to the clinical anatomy. Subluxation of radial head, also known as pulled elbow. We have discussed this thing about the annular ligament. Now coming to Colles fracture. What is Fuchs? So this is a mnemonic for fall on outstretched hand. You cannot write these things in the exam paper. For my convenience, I have written like this. But it is a proper mnemonic. You will see in any book, any standard, like not standard book, like any reference books, you will see it as Fuchs. So Fuchs means fall on outstretched hand. Like if the hand is outstretched like this and if a person falls like this, usually Colles fracture occur. And usually it occurs in the children. What happens? You have seen dinner fork, na? Fork. So dinner fork, it appears exactly the same thing only. Colles fracture also. This part will go, if someone falls like this part will move front and this will go behind. So it will form something like this. Okay, it will appear like a dinner fork. And the opposite thing occurs with Smith-Peterson fracture, also known as simply Smith's fracture. If a person on hyperflexed wrist, this is flexion, this is flexion, this is hyperflexion. If a person falls like this part will go in front and this will go behind. It will form like this pattern, a garden spade, which we usually use in our garden. Similarly like these things. If you see these pictures like in Google, you will just clearly understand. And weight transmission. Regarding weight transmission, if a person falls on their hand, first of all the weight of his or her body or the impact is usually transmitted to which part? Not the body, like the impact of the road usually transmitted to which part? In the hand. Followed by radius or ulna? Radius. Followed by ulna. Why not both radius and ulna? Because in the inferior radioulnar joint, radius has more contribution. And in this portion, in the elbow portion, the ulna has more contribution. Okay, so here the radius bone will undergo fracture. Due to this reason, you will see that in Colles fracture and Smith-Peterson fracture, usually the radius gets broken. And in elbow, the ulna gets affected. Okay. Now coming to, now after that, the humerus is undergoes fracture, followed by clavicle and followed by ribs. And this is a very like traumatic fracture if it goes up to the ribs. So various other things occur like pneumothorax. If the bone pierces the lungs, then pneumothorax occur. Sometimes hemothorax occur. What is pneumo? Air. Pneumo means air. Thorax means in this region, in the thorax region, and it inserts the lungs, so it is known as pneumothorax because air is present inside the lungs. So it is forming like the lungs is covered. If it pierces, then it forms a go and throw like fashion. So the air, outside air can insert inside and just disrupts the atmospheric pressure inside the lung. So that much only.